We are here with Dr. Amy and Michelle Pearlman of the Prime Institute here in Coral Gables, Florida. Dr. Amy is a genitourinary surgeon, sexual medicine specialist, board certified in urology. Yes, I am reading this straight from your website. And Dr. Michelle is a physician nutrition specialist, board certified in internal medicine, gastroenterology, and obesity medicine. And they are sisters, if you can't tell by their beautiful faces. Um, First, before we get into nutrition and urology, what inspired you guys to start a clinic together? Why did you decide to combine nutrition and urology?
So
I
I'll
guess
start.
I was going to say I'll start, but well, we're both wearing pink today and we like to cut each other off. So I'll let Dr. Amy start.
I love it.
A lot of people ask us that question. How in the world does a urologist end up in the same practice as a gastroenterologist? We actually share a ton of mutual patients, which we'll get into. My career started off at the University of Iowa, where I was directing the men's health program. Michelle's career started off at the University of Miami, where she really started and was directing their weight management program. And our mission is to help people live like at the prime of their lives, right? And to maximize the time they have on this earth. But we were both in academics and we had lovely careers and we helped a lot of patients. But we found over the last few years before we started our own practice, we were complaining about a lot of different things. And we just had this fire under our butt that was like, we can't waste any more time. We got to move. And I don't want to set up another meeting to discuss the next meeting. And we were tired of complaining about it. And so one day we said, let's stop complaining. Let's do something about it. And
Love
there's
that.
never a right time to start one's own practice. You never feel completely ready. But we started Prime Institute 3 years ago at the beginning of 2023. And we've kind of made our practices more focused, but then have also expanded and evolved in certain ways. So historically, I was a men's health specialist, and pretty much the majority of my practice was seeing men. And now my
Mhm.
practice has evolved to seeing women who have genitourinary syndrome of menopause with common symptoms like urgency, frequency, and pain with intercourse, as well as women with low libido. And Dr. Michelle's practice has also evolved. So Michelle, you want to go into that?
Yeah, so I'm trained as a gastroenterologist. I offer, maybe second opinions for more complicated gastroenterology issues, but most of what I do is focusing on nutrition. Most of the patients that come to see me are interested in losing weight, although I do see a handful of patients who are trying to gain weight. Sports nutrition, and then just like Dr. Amy said, my practice has evolved where I now do HRT for perimenopause and menopause.
So
Love
our
that.
combined, like our most successful patients, and I think where we can really help people thrive are middle-aged people. And oftentimes people think of middle age or that term as being someone in their 50s. Middle age is late 30s, right? Average
Uh,
age of people in the United
so
States
exciting.
is 77, right? But it's
Yeah.
okay. It means that, like, yeah, when we talk about middle age, it means we need to be more proactive earlier on in life. We can't wait
Yeah.
until someone's in their 50s. Like, really, this has to happen starting one's 30s, if not earlier. And so we realize that we can help middle-aged people, men and women, really optimize their health at this critical period, this critical decade in their lives. We can really improve, their not only their lifespan, but their health span.
Yeah, we were talking to one of the PTs here. Him and I, both of us are in our late 30s, and he was saying that we just both read something about 35 to 45 is kind of like our critical decade, where the things that we could get away with in our, teens and 20s aren't really serving us anymore. And also, we're setting the stage for our later stage life. And all of these changes are starting to happen in our bodies, hormonally, especially for us women, and nutritionally and aging wise. And so it's interesting that you say that, because I think so many people wait until things get really bad to then start the ball rolling, and at that point it's like you're digging a hole that's so deep it's so hard to get past that. And I think it leads to a lot of people that are struggling with the idea that they can get help or they can get better because they feel like they're so far behind. It's like losing all of that weight when you've got 200 pounds to lose versus losing that weight when it's just 10, right?
Or
Um,
preventing the weight gain in the first place, right? If we know the
yeah,
average woman
exactly.
may gain 15 pounds, of weight during perimenopause, once it's on, it's a hell of a lot harder to get it off. as opposed to being a little bit more proactive. But
Yeah,
I
for
will say
sure.
that it's never too early and it's never too late, so you can always make changes. But it's like the typical person that retires and then thinks now they have all the time in the world. Now they're going to exercise every day. And the reality is, if you didn't build those habits when you were younger, you are magically
Yes.
not going to become a gym rat and, be at the gym at 7 a.m. and start eating protein. So habits are much harder to change as we get older.
Sure, absolutely. So for you, Dr. Michelle, what is something that you wish every client or person knew as when it comes to nutrition and their health?
Yeah, I think two major things here. We're so weight focused. That's what people care about, the number on the scale. I was listening actually to a podcast earlier this morning, and it was Gabrielle Lyons talking, and her way of practicing medicine, she calls it muscle centric medicine. And I actually love that phrase, right? To focus less on the number on the scale, more on how do we maintain or build muscle, and what Dr. Von der Wright talks about is aging with power, not aging with frailty. And that
Mhm.
requires a couple of different things. It requires eating enough protein. It requires stimulating the muscle and not just telling people to exercise or to move their body, which is a first step for many, but it's strength training and doing progressive overload over time. And then, hormone optimization. So you need three of those critical things. Obviously, stress management, improvement in sleep and coping, and all those other things play a role. But when we go to the nutrition, protein and fiber are really the key factors here. Focusing less on calorie centric diets and more on, am I eating whole foods? Am I getting enough protein to stimulate muscle? Am I getting enough fiber to optimize the gut microbiome? When you focus on those three critical components, people tend to not overeat because fiber and protein are very satisfying.
Yeah, yeah, the satiety is there. Um, you work with, or at least you have worked with, like athletes and high performers, sports nutrition. How does working with that population overlap with the pelvic and sexual health aspect or the urology aspect of the practice?
Yeah, it's interesting. Many of the guys that see me also see Dr. Amy for hormone optimization, and they're looking to take things to the next level. They're the not focused on the number on the scale, but they're working on body recomposition, but also improving performance. So I think a lot of these men would go to a standard primary care doctor and say, "I want to gain muscle and I want to lose the love handles." And I imagine most of those guys, were probably being told eat less and move more, and cut out
Right,
some of the alcohol. And that's kind of a standard conversation that people have. But the reality is people need more guidance and people need to understand, going back to the nutrition, what's important for that person, male or female, depending on where they are in their life and what sort of event or sport are they training for, right? My
right,
guidance for a marathon runner is vastly different from someone who's trying to make, significant strength gains in the gym. So it depends on really what the person's goal is, irrespective of the number on the scale. And then just, gut health in general. Just because someone is normal weight doesn't mean they have normal bowel movements, or doesn't mean they don't suffer from chronic, constipation. So I see a lot of patients with chronic constipation. Either they're sitting at a desk, death by Zoom, right? Um,
hmm,
whether or not they've had surgeries in the past, a lot of them have it. We used to think that it was only women with vaginal deliveries and forceps deliveries, right, that had pelvic floor dysfunction. Very
yeah.
far from the truth. A lot of my patients have it. And it all goes back to what are their risk factors and what are things that we can do to mitigate a lot of that.
I think
So,
going back to your question, in terms of how that nutritional guidance overlaps, it's really at the foundation, it's all this shared message, which is anti-inflammatory foods are good for brain health, heart health, gut health, joint health, sexual health, hormone health. So really
right.
the foundation of the nutrition is all the same recommendation. Eat your fruits, eat your veggies, lean protein, nuts, seeds. Foods like that are going to be helpful for all the different patient populations that you're describing.
Yeah, absolutely. And to piggyback off of that, what would you say, like what patterns or lifestyle factors? I know you talked about death by Zoom, right? As we sit here on Zoom. Um, what do you see impacting both your males and females as far as like pelvic or sexual health the most? So is it the inflammation? Is it the gut health that seems to be, the biggest impact? Is it just like what people are eating is, those over processed trash foods that are just inflaming everything? Or is it body composition? Is it stress? Like, what are you noticing?
Yeah, I mean, I would say stress plays a big role. I see a lot of attorneys, so stress plays a big role. Poor sleep plays a big role. We are in Miami. People do enjoy drinking. That plays a very big role. The majority of patients that are seeing me, they are, investing in their health and wellness. So for the most part, they're eating quite healthy, but a lot of them are on GLP-1 medication. So we know that the most common side effects of GLP-1s are going to be GI symptoms like constipation. So if someone has baseline pelvic floor dysfunction, the GLP-1s may actually make that worse. Because they're less hungry, they tend to eat less fiber, and they tend to be a little bit less hydrated. These medications have diuretic effects and they tend to, their thirst tends to go down. So if someone has any sort of underlying GI issue or pelvic floor issue, I unfortunately am sometimes making these problems worse, which makes it even more important, right, to take care of the pelvic floor so people don't get stopped up and then end up in the ER.
Yeah. Wow. That's so true.
And then my
Um,
response to that question would be people are as simple or as complex as we allow them to be. So often in medicine, someone comes in and their chief complaint on our schedule says erectile dysfunction, premature ejaculation, right testicular pain. But when we actually ask that person questions for the sake of understanding their concern, it's typically not just right ball pain. It's typically not
right.
just erectile dysfunction. It
Right.
is very common in my office that when I have someone come in for ED, we talk about urinary symptoms, constipation, right testicular pain, low back pain. When they have this compilation of symptoms, it becomes so obvious to me that this person would benefit from seeing a pelvic floor physical therapist. And I think going back to that question of how did my sister and I start this practice together? What is our overlap? We're all specialists in pelvic organs. And people talk about the pelvic organs as being nosy neighbors. So if someone is constipated or has some bloating, they're probably also going to have some other urinary issue or some other type of pelvic pain. So we cannot just treat the colon in isolation or the bladder in isolation or the ED in isolation. We have to
Right.
broaden our understanding. And you are like that, the person that bridges my sister and I, right, in terms of
Hmm.
the pelvic health.
Yeah. And it's so interesting because we get a lot of patients who don't realize that the constipation is also a pelvic floor issue, right? So they're like, oh, I've been constipated my whole life. I actually had a lady recently that was post C-section. She just wanted her scar looked at. And then as I was taking her history, I'm like, okay, I know you've had 3 C-sections. Do you suffer from constipation? She's like, oh, yeah, it's since I was a kid, took mineral oil. And I'm like, okay, any pain with like tampon insertion? No, no, I don't wear tampons because they bother me. I wear pads since I started menstruating. And she uses a child speculum or an adolescent speculum when she goes for her OB visits. She doesn't enjoy sex with her partner because it's not comfortable. And as we're going through all of this, she was like, that's a pelvic floor issue. And I'm like, oh my goodness. Um, but that's many patients, right? There's a lack of education, I think, in childhood and even adulthood, right? Around what is the pelvic floor. People don't realize that there's muscles there, that those muscles are helping everything else, the organs to do their jobs. And so it's interesting that you say that because everything is so connected. And I think that it's hard for people to grasp that concept of all of that interwovenness because it's easier to just say like it's this one thing and I just need you to fix this thing. And when in reality it is, to your point, Dr. Michelle, it is the nutrition aspect, right? It is, how are you moving your body? Are you sitting at a desk all day? Because that's really probably not going to be, the friendliest option for your pelvic floor. But it's, I think in our society, in healthcare today, everything is geared towards a fix, like a pill, a surgery, this one thing over here. Dr. Amy and I were just talking about, how some doctors, their preference is to push the pharmaceuticals as their first line of defense. And hers is to really look at that, like, how can we address this from all of these other angles before we venture into, what may or may not work medically. So I find that very, very interesting. Tell me from both of you, and I know, Dr. Michelle, you probably have to head out here soon, but what does your assessment look like? What types of physical assessment or screening tools, like what are you using when someone walks through your door and says like, hey, this is what I'm here for? What does their first visit with you typically look like?
Yeah, so I'll start. So patients who schedule with me, we try to make it very clear what sort of services I offer, so there's no surprises. And, a lot of times when it comes to weight, it's a very sensitive topic. But by the time people schedule with me, they're kind of giving me permission, obviously, to bring that up, as opposed to me being, let's say, an internist, where sometimes bringing up that conversation can be very difficult if the patient's not expecting it. So my initial consultations are usually anywhere from an hour and a half to 2 hours, go over their full medical history and really delve deep into, their prior struggles. What have their weight trends been? Have they tried medication before? What does their exercise routine look like? What do they like to eat? What do they not like to eat? What does their family household look like? Who does the cooking? Who does the grocery shopping? So I really get into the nuts and bolts of their nutrition history as well as exercise. Again, it's not good enough to say, okay, are you exercising? I want to know, do they have a trainer? If they don't use a trainer, what sort of equipment are they using and what do their rep ranges and sets look like, so that I can give them more nuanced guidance. The majority of people who schedule with me are interested in GLP-1 medication, so that typically is part of the conversation, but by no means does that mean that every single person needs it. I have several patients who just see me for more of the dietary counseling and exercise. And then once I go over a whole PowerPoint of educational materials as it pertains to cardiometabolic health. And then, we figure out what sort of steps they're willing and what they want to take. If they're interested in a weight loss medication, then that does require a 6-month program where I see them monthly. So they come in monthly, I get them on my Seika bioimpedance scale, where I'm able to track their muscle mass, their visceral fat, their body fat, critical things that actually matter as opposed to just looking at that number on the scale. A lot
Yeah.
of the online kind of commerce sites, basically they're selling weight loss. It's become weight loss commerce. And really my goal is, although someone what's bringing them into my clinic is to lose weight, my goal is how to reduce risk of frailty, fracture, and improve their cardiometabolic health. As a result, they will lose weight, but it's focusing on, health span, as well as lifespan. And then for my hormone replacement therapy patients, really, the initial assessment is pretty similar. And again, people who are interested in hormones will also sign up for a 6-month program. But many patients of mine, on the HRT side aren't necessarily concerned about the number on the scale, but the women have noticed body composition changes. So even though the number's the same, they're noticing that menopause belly and things aren't fitting like they used to, and they want to improve their brain fog and get rid of some of those vasomotor symptoms. So I love what I do. I'm very grateful for what I do. And the nice thing is obviously I'm helping the person sitting in front of me, but as they're learning about how to optimize lifestyle behaviors, everyone in the household tends to also benefit, which is great.
Yeah, that's amazing. And Dr. Amy, what does it look like for you? So someone walks in, they've got erectile dysfunction, right testicular pain, all the things, and they walk in your door. What does it look like your first day with you?
They walk in with all the urologic maladies. Huh? So the first thing I do is I give all patients a tour of Prime Institute, and we have 7 rooms in our office. And the first room that I give them a tour of is actually a room full of sex toys. And I
Love
have
that.
been verbalizing this recently where I say, I'm going to give you a tour. This is the first room. This is today's icebreaker. And what I think it does is it shows people, rather than me telling them, that anything you want to talk about is on the table today, right? And so do I discuss sex toys with everyone that walks in my door? No, but I will for anyone who wants to. And then it's also a place where we can talk about taking people from purpose to pleasure. So a lot of that room is understanding how do we optimize someone's pelvic floor, getting them acquainted at least with, let's say, a vaginal dilator or a pelvic wand, so that let's say when they're seeing someone like you, they've already seen a product like this before. So
Right.
I give them a tour, and then I do, similar to my sister, an initial like 90-minute visit. And this is both for men or women. We go over their whole health history. Much of my time spending with patients is in a room just like the one that I'm sitting in. I don't do any exams in this room, right? I want to separate the two. So much of the time, I am, even as a surgeon, I'm sitting down and I'm talking to my patient. Only when we need to do an exam, which could be maybe 30 seconds out of the visit, do we go to a separate room and I turn down the lights and I try to make it as comfortable as possible to do the
Sure.
exam. And then we finish off the visit in this room. I don't want people to think that every time they go in to see a urologist, they're going to pull their pants down and bend over. I try to practice, to the best of my ability, trauma-informed care. When it comes to
Mhm.
trauma-informed care, oftentimes we think about that as this person that we're seeing has to have suffered some trauma to warrant getting trauma-informed care. And yet everyone who walks into my clinic deserves that. All it takes sometimes is one digital rectal exam or prostate exam that was uncomfortable that caused that person trauma, where he will no longer trust a healthcare provider. So I
Right.
try to really set that scene that it's not like a typical urology visit where everyone who comes in is up in stirrups or bending over. Okay. So I have this, full discussion with patients. I have in my office here, I'll try to turn my computer. Let's see if we can get a little view. I have so many demos in my office. So this is a room where I see men. I have this whole wall of pelvic anatomy and back anatomy, and then this is for like penile, genital stuff, and fertility. So I like when my patients get to see exactly what I'm talking about when I'm talking about therapies. If I hold up a needle and I say, look, when we're talking about testosterone, this might be something that you use. If they look at it and that's not for them, then we can make that decision in real time, whether or not that's going to be something in our treatment algorithm. So I like to show a lot of demos. I have a whole separate room actually for women, and we have like a lounge area because as I've started seeing more and more women, and this really is true for men as well, is I've realized that people come in with a lot of baggage, or some of my patients do. And so sometimes people don't want to sit in a room where there are sex toys behind me, right? And
Right.
so sitting in a room or giving that patient a choice where they can sit on a recliner, I can sit in a chair, and there's no, toys in that room, can also be helpful. And then I do as needed visits. So I really let my patients dictate what type of follow-up they want. So we do that initial visit, and I might say at the end, when would you like to follow up? We discussed a lot today. My goal definitely was not to overwhelm you. Do you want to see me back in a couple weeks, a couple months, 6 months, 3 months, whatever it is? And they decide. Now, I have a little bit more closer follow-up on patients that I'm putting on hormone replacement therapy for my male patients for whom I'm treating low testosterone, which I do a lot of. Those patients, if I'm starting them on testosterone, I'll check labs and see them back in about a month, and then 3 months later, and then every 6 months. Otherwise, it's really as needed visits.
I love that. And are you noticing particular trends in your practice? So, are your male patients coming in younger? Are they more open about the pelvic and sexual issues? Is there still a lot of like fear, shame, hesitancy? Because I know for us, at least, the male patients that we see often seem to have been dealing with their symptoms for a little bit longer because I think there's more hesitancy to seek care. It's more of a, well, maybe this will just kind of resolve itself on its own. Let me just not do that thing that I was doing that's causing me pain there. And so there, at least in our practice, it seems like people are waiting a little bit longer, at least on the male side of things, to be seen. Are you noticing the same thing in your practice, or are people either more educated or just more open to the idea of seeking out care earlier?
Mhm. I see the full spectrum. I will say, what I think a big difference is between my current practice, having a concierge practice, compared to when I was in a big academic center, is when people come to see me, they know exactly why they're here.
Yeah.
Oftentimes they've done their research, they've looked online. I love a well-educated patient, but I also have a lot of patients that haven't done their research, and that's fine. So oftentimes I'll ask them, How many rabbit holes have you gone down? And I don't say that as a in a derogatory way. I'm just kind of curious, like, have you been looking online at different things for the last 10 years, or did you just see something pop up and then you saw my name and decided to schedule a visit? It gives me a foundation or an idea of how much detail they want during the visit. So I'm not repeating stuff that they might already know. I
Sure.
love when my patients come in and they say, Dr. Amy, I had a conversation with ChatGPT and this is what I
Oh
found out, and I'd like to get your thoughts on it.
yeah.
I really like that, right? Because in so many ways, like ChatGPT is really good at emphasizing lifestyle behaviors, right? It tells
Yeah.
patients a lot of things that we as healthcare providers don't know how to say, like you need to eat healthier, but it'll like tell patients like you need to eat healthier, and these are some good
Yeah.
options, right? And so I look at that as like a great way to start the conversation. Now, there are a lot of things online that aren't true or misconceptions or outdated. And so that's really what my role is in the office, is to say, yeah, this is where there's research behind what you're saying. And we actually don't have a lot of research to support that claim. So maybe we can just kind of like throw that out the window,
Right.
but I do find a lot of my patients are pretty well educated. And I do find, especially my patients with pelvic floor dysfunction, they've been suffering for a while. I'm rarely the first person that they're seeing. And I think, and oftentimes they've been like misdiagnosed and treated for bacterial prostatitis and put on all sorts of
Yes.
antibiotics. And so my job in these scenarios is to help them understand why seeing a pelvic physical therapist is so important. That's where this wall behind me is so critical, showing the anatomy. I could paint a picture of what the pelvic floor is. That doesn't do anything. I can take out one of these pelvic models. I can say all the dark red right here are all the pelvic floor muscles. And you kind of mentioned before that sometimes people are looking for the easiest or the most simple, solution to talk about their ED, when the simplest explanation for all these symptoms that people come in with is pelvic floor dysfunction. It is the common
Yeah.
denominator, right? And so when I show them, oh, the muscles, they surround that organ, they surround that organ, look at how close these two organs are. It's like this light bulb goes off. And it's rare,
Yeah.
when I recommend a patient see a pelvic physical therapist, if they say no when they see the anatomy. And I
Right.
tell them, look, if there's one provider that I routinely refer my patients to, where my patients come back and they say, Amy, that person changed my life, it is the pelvic physical therapist. But my job is to convince them of that, because I already know this. I know they're going to
Right.
come back. I know they're going to get better. But if they haven't heard of it before, it's a foreign concept. So
Hmm.
over the years, I've perfected my talk track to help them understand, you have to trust me with this. This person is going to change your life.
Well, we love having advocates like you.
Yeah.
And it does, I mean, it is such collaborative, it's a collaborative space, right? And to your point, I think some people, they know what physical therapy is, but to think of a pelvic floor therapist, I've had patients that have come in that went to their doctor said, oh, you need physical therapy for that issue. And they went to an orthopedic physical therapist, and then orthopedic physical therapist was like, you need to see a pelvic floor PT. Like we don't do that here. So I think there is also some lack of awareness around what a pelvic floor PT does and what they do differently than our ortho PTs or a neuro PT or a peds PT or any of the other specialties within the physical therapy realm. What gaps do you think exist in kind of our global healthcare system or standard medical system that you feel like pelvic floor PT could help bridge?
I think one of the big problems is we rarely sit down with each other and say, what do you do? What do you like to do? Who can you help?
Yeah.
And I remember this is back when I was in Iowa, and I went to tour like a multi-specialty clinic, and I was interacting with the urologist, and I was asking him about his practice. We were talking about pelvic physical therapy, and he said, yeah, I refer my patients to a pelvic physical therapist. They're in this building, but I've never met them before. Now, I didn't react this way like in person, but in my mind, I'm like, wait, you refer a patient of yours to someone in this building. It's not that big of a practice, and you've never met this person before, and you're routinely referring them. It is so rare, if ever, that I refer a patient of mine to someone I've never met before. I had a patient, this was several months ago, who said, hey, I had back surgery by a neurosurgeon, a few years ago. I just moved to this area. I need to establish care. So I went to a colleague at Baptist. I said, hey, who's your back guy? Who's your neurosurgeon that you recommend? I need the best one you got. So he sends me his information. He makes an intro. I schedule a Zoom call with the neurosurgeon to know, like, hey, so I had this guy, he got back surgery. Is this someone, do you only treat patients who like need surgery, or would you follow them after someone else
Right.
did their surgery? And he was like, yeah, I'm happy to see him. Give him, give me his information. But we all, as healthcare providers, you, me, and everyone that we work with, we all like and specialize in different things. The last thing I want to do is refer my patients to some neurosurgeon who has no interest in seeing that patient. The
Right.
only way to know is to sit down with our colleagues and say, what do you do and what do you like to do? It's one thing if you can treat 100 different things, but I want to know, what do you like to do? Where you, when you see a referral from me, you say, heck yeah, another Perlman referral, versus, God dang it, another Perlman referral. She has no idea what I actually like to see. And
Right.
when we send the appropriate patients to the right provider at the right time, everyone wins. Every
Yep.
single person wins. So, when I kind of started this understanding what pelvic floor physical therapists do, this is when I was at Iowa, and I scheduled a meeting with all 4 pelvic PTs at the University of Iowa. And I said, Natalie, what do you like to do? Who do you like to treat? Amy, what do you like to do? Who do you like to treat? And they listed all the symptoms. That's the bane of every urologist's existence: urgency, frequency, constipation, fecal incontinence, testicular pain. And I was like, whoa, you guys can help so many of my patients. So I think I have a good understanding of who people like you can help, because I've sat down with you and your colleagues to understand that. But not enough of my colleagues actually sit down with their colleagues to say, who can you help? I
Yeah.
think anyone, any patient who has any type of genital pain or any type of genital concern should see a pelvic physical therapist. That is the
Hmm.
hill I'm going to die on. That is the most conservative therapy. I would offer that even before starting medication. Now, do I make people see a pelvic physical therapist before I do anything else? No. But I say,
Right.
look, it is part of the treatment. I can still put you on Cialis. I can still offer you other things. But if you want to get at the underlying issue, I would highly recommend you see a pelvic PT.
Yeah, I totally agree. As a PT, it can be really difficult to actually touch base with providers and urologists, OBs, endocrinologists, like anyone that might be seeing a patient who is a good candidate for pelvic floor PT. It has been really challenging to be able to say hello, to walk into an office and like sit down and just, hey, I'm Dr. Ariane. I'm a pelvic floor PT. This is where we're practicing. Here's the people that we tend to see the most of. And we like to know who our providers like to treat also, right? So it's been really great. And thank you because I feel like you have, since I met you, I don't know, what was that, a year and a half ago that I met you for the first time? Um, you have been kind of an open door where you're very responsive. I can shoot questions to you. There is a collaboration there. And I think in healthcare, that's a lot of what's missing, right? Is that you might kind of give that like lob referral, like, oh, well, you could, I get a lot of people that are like, well, my urologist like didn't know what to do with me. So they just said like maybe pelvic floor PT. But it was like a very like, you could try it, see what happens. And so they're already coming in the door like, can you help me? I'm not really sure because my urologist didn't seem convinced, or this other person was like, you don't really need that. Let's just do this medication, or like, let's just do this surgery. So with that said, who is your bread and butter? If someone is having erectile dysfunction or pain or any other issues, and you said like, Ariane, I want you to send if you have any patients that fit into this kind of general vicinity, those are the people for me. Who would
Mhm.
it be?
So let's start with women. So for women, I treat women who have genitourinary syndrome of menopause and some of those symptoms that I described. So like urgency, frequency, nighttime urination, pain with sex, reduced lubrication. Now, a lot of these women would benefit from seeing someone like you. So I'm treating them more from like a medical standpoint in those scenarios, right? So for those patients, I'm educating them on their anatomy. And I'm also going to be offering pretty much all those patients vaginal hormone therapy, for which I feel very strongly. And the FDA FDA recently put out a big announcement that they're removing the black box warning off of,
Yes.
vaginal estrogen products because
Hmm.
vaginal estrogen does not cause blood clots and dementia and heart attack and stroke. So it's a very safe medication. So from my point of view, like for women, it's a pretty defined group of people. It's women who would benefit from vaginal hormone therapy. So I'm putting them on vaginal estrogen. Some patients benefit from vaginal DHEA. Those medications are also very important to reduce urinary tract infections and help with a lot of those symptoms. So what I tell my patients, especially if they're coming in with a lot of pelvic floor symptoms, is using this in combination with pelvic floor physical therapy is going to get you the best results. It's not this versus that, right?
Right.
It's really the combined approach. And then I see women who have low libido. They want it, they just don't want it. But I wasn't seeing women initially, and I was seeing all these guys, and I was putting them on Cialis and optimizing their hormones, and they felt great, and their partners didn't want to have sex with them. And that's a problem, you know?
Right.
And so I would tell them that's a problem, and your wife should get some care somewhere to see if she's interested. She should see someone who specializes in female sexual health. And what I found was that it was pretty hard in South Florida, despite how, metropolitan this area is. It was
Yeah.
hard to find a female sexual medicine specialist who had openings in her schedule to see these patients. And so, I tell my patients to, I'd give them some names. They would come back 3 months later, 6 months later, and say, oh, my wife couldn't get an appointment. And we're still, where we were 6 months ago. And I felt like we were wasting a lot of time and we weren't making any progress. So one of my colleagues, Dr. Rachel Rubin, was about to teach a course on female hormones and sexual medicine. And I'm like, you know what? I think it's time I evolve my practice a little bit. And so I started treating women over a year ago. I freaking love treating women. I thought for many years I couldn't help women. I thought women were too complicated. I thought we had no tools in our toolbox. And then I've realized, yeah, we have a lot of tools in our toolbox. It's just nobody really knows about them. And so now we
Hmm.
have two therapies that are FDA approved in premenopausal women that I can actually safely use in perimenopausal and postmenopausal women off label. So I love seeing women because if I can give them the itch they need to scratch, where having sex with their partners is no longer obligatory, but it's something they actually want to do. And now maybe they're initiating, maybe not every time, but maybe they're throwing their partner a bone once a month and initiating. That can completely change the relationship dynamic. So if a woman is coming in and she's going through perimenopause and menopause and needs more systemic hormone therapy, which every woman deserves that conversation. I'm not saying every
Right.
woman needs to be on systemic hormone therapy, but every woman deserves that nuanced conversation. That's where they
Sure.
would start off seeing my sister. But systemic hormone therapy is oftentimes not enough to treat the genito and urinary symptoms. So
Right.
oftentimes women, to optimize their symptoms, they really need systemic hormone therapy and local
A
vaginal therapy.
local.
Yeah. And then for
Would,
men, oh, go ahead.
well, I just had a follow-up question to that. So would you say of the women that you see for low libido, and I'm sure that there are women that are going to watch this that are wondering this question, how much would you say is truly a hormone issue, right? Versus carrying the mental load of the household, especially if they're a working mom, business person, going home to cook dinner at 5 p.m. and help with homework and bath time and bedtime and they're touched out. Do you see the women who maybe their hormone panels are mostly within that normal happy range, but they're still facing the low libido? And can you assist with that regardless of hormone levels?
Mhm. Look, it's challenging, right? We talk about treating people with a biopsychosocial approach, and I really try to use that, as my approach with patients, but it takes a lot of time. It's complicated.
Yeah,
It's rare that someone's concern, whatever it is due to one thing.
right.
The only way to separate out life stressors from hormones and other things, like you can't do it. We
Yeah, it's
don't
impossible.
that would be great. It would be wonderful.
Yeah.
And so we control what we can control, and we do kind of the best that we can. And I asked myself, Dr. Rachel Rubin, who I mentioned before, asks this question all the time when I ask her questions about, hey, what do you think about using this medicine and this type of patient? She's like, Amy, what are you afraid of? And there are some things that I'm
Mm,
afraid of, and not like, are you afraid of the dark type thing, but like,
yeah.
there are some ways that certain treatments I offer can hurt patients, right? And so it's really important to define that. But once you define that, for a lot of the medicines that we use, they're very safe. They might not be effective in everyone, but you kind of say, what's the worst that could happen? It doesn't work. Okay, then we move on to something else.
Right.
And so, for these women that come in, you can't rely on labs because women, as they're going through perimenopause, their hormones are drastically fluctuating depending on when you check it. So just because you check someone's labs on a Wednesday and their hormones are normal doesn't mean they're not going through perimenopause,
Right.
And so when it comes to even treating someone with systemic hormone therapy, and by that I mean testosterone, estrogen, and progesterone, treatment is based on symptoms. Treatment is based on symptoms, and some people you don't even need to check labs, honestly, for someone to warrant being on systemic hormone therapy. So where do my ears perk up where I'm like, oh, maybe this woman's going through perimenopause and menopause? Women in their late 30s and up,
Yeah.
because the average age of menopause is around 52, and perimenopause starts 2 to 10 years beforehand. And perimenopause and menopause is associated with 70 different symptoms. So, as we discussed before, yeah, sometimes it's like, oh, my skin is a little bit drier and I have some reduced lubrication. And so you can kind of blame it on 70 different organ problems, or the
Yeah.
simplest reasoning is perimenopause, which could explain
Yeah.
all 70 of those symptoms. And when we talk about systemic hormone therapy, we're talking about such low doses of hormones that if someone doesn't like it, they can always stop. And in general, it's a
Right.
very safe therapy for a lot of women. And when it comes to local vaginal hormone therapy, I mean, that stuff doesn't even get absorbed systemically. So, if someone doesn't like vaginal hormone therapy, we can always stop it. I'm really not afraid of anything.
Right.
And then, I ask my patients, is the sex worth wanting? Because even if I improve someone's libido, if they never orgasm during sex, why would they want it?
Yeah.
But I
Yeah.
have a lot of
Absolutely.
women, I have some women that say, yeah, it's not worth wanting. And that's where I might recommend a really good vibrator, or that's
Yeah.
where I might
We
give them some,
re-enter door number one.
yeah, that's where I'll give them resources to online courses. We think that all porn is bad. All porn is not bad. And
Right.
it depends on the person. Actually, women who watch porn can get benefit out of that.
Hmm.
But in general, it depends on the type of content, and more violent or aggressive pornography, especially for men, is not going to be helpful. Whereas
Right.
the resources I direct patients to is teaches people how to make passionate love making with their partners. And sometimes people need to learn technique. Sometimes people need to know what tools they have available, like different vibrators and clitoral suction devices. Sometimes, I ask my patients, do you like your partner? How's your relationship? If you don't like your partner, it's going to be really challenging to want to have
Yeah.
sex with them. So I work with, and is it painful when you have sex? It's where I'm sending someone to see someone like you, or I'm sending them to see a sex therapist. I think in my
Hmm.
visits, oftentimes when I tell my patients, I really think it would be beneficial to talk to a therapist. Let me give you some recommendations. They're like, but you're my therapist. And I'm like, but I'm not your
You're like,
therapist. I'm not your therapist.
uh-uh.
I can listen to you, but I can't really provide, um, evidence-based guidance other than
Yeah.
sometimes I have such a big mouth where they're like, should I get a divorce? And I'm like, I mean,
Yes.
what you're telling me, I'm hearing from you that you feel like you need to get a divorce.
Yeah.
But that's challenging. That's where I rely on a lot of people like you and others to help in these
Yeah.
scenarios.
Yes. Also not a mental health therapist, but I feel like it sometimes.
But
It's
I
so
think a
true.
lot of us, we have to reinforce each other's messages
Yeah.
and know, I'll ask my patients, okay, so you saw a pelvic physical therapist and it was helpful. What about it was helpful? Was there a specific exercise? Or at what point did you feel like you got benefit? Because I'm learning through my patients how to counsel the next person. But
Right.
I really learned a lot about the benefit of pelvic PT was when I was at Iowa and I had happy patients coming back. The problem is if we have a patient that we send to see someone and they do well, if they never see us back, we never know what happened. You
Right.
know, and so it was helpful when patients came back and they told me exactly what was beneficial for them. And that really helped, with my future guidance.
Yeah. I know we kind of derail from this, but really quick, when it comes to men,
Yeah.
who's your person?
Yeah. So
Who do you
I
want to see?
okay, it's a variety of things. And I would say my expertise, because much of my training is in men's health, is where I will go really in any direction that a man wants to go. I'm happy to delve into it. So I see men for well man's visits, which is not really a thing, but I'm
I
trying to
love
make it a
that.
thing.
You should make
because
it a thing.
yeah,
Coin
because
it.
we can we can call a gynecologist office and say, I want to schedule my well woman, visit, and no one
Hmm.
blinks an eye. But, for men, there's no healthcare provider that has any mandatory training in men's health. Now, with that being said, there's this kind of like divide, which is like men versus women in the healthcare system, and men have it so good, and men get all the ED drugs, and no one's paying attention to women's sexual health. But I will tell you, a lot of people are not paying attention to men's sexual health as well, because a lot of people don't know how to answer the everyday questions of everyday men. Like if someone says, "Oh, I'm 60 years old and I don't ejaculate anymore," like what do you think is going on? People will say like, "Oh, well, less mess." Well, hey, ejaculatory function is really important in guys. Or people might say, how often should I masturbate? Well, there is some science behind masturbation and orgasms. And honestly, like there's, some research to say that if you orgasm 21 or more times a month, that's good for prostate health. So that's helpful for people to know. But like most people don't know that information, right?
Right.
So I am happy to see a guy who, let's say, is, 30, 40 years old and says, I want you to tell me what I need to know with the information I provided. And then I can say, all right, let's start with hormone health, and we'll go through hormone health, and I'll tell him what happens starting at the age of 30 in terms of his hormones. We'll talk about fertility. We'll talk about urinary and pelvic health. I will go down any rabbit hole that person wants to go down. In terms of like other reasons that men would specifically see me that are more, focused would be any type of erectile dysfunction. But ED is like, everyone's heard of ED, right? But I treat
Hmm.
all types of sexual dysfunction. So it's not as simple as ED. It's guys who have premature ejaculation, guys who have delayed ejaculation, where sometimes, or maybe all the time, they're unable to climax with their partner with masturbation. They have reduced sensitivity to their genitals, where it takes a lot of work, to even reach any sort of like erotic stimulation. I see guys with any type of pelvic pain, testicular pain, tip of penis pain. I see guys, I do see some guys who have urinary symptoms, but I did a lot of that when I was at the University of Iowa. That's not a focus of mine right now. So if someone needs more of an evaluation for bothersome urinary symptoms, I do send them to see one of my colleagues who offers more of a nuanced approach. And then I see guys for low testosterone, guys who are curious. What is my testosterone? I'm happy to check it. And then I see guys who are interested in banking sperm for maybe their future, or want to see what their current, sperm parameters look like. And I see guys for girth enhancement. So guys who want bigger penises. We talk about kind of this nuanced approach between preserving penile size, restoring size that maybe they've lost over the years because let's say they have scar tissue in their penis or they have erectile dysfunction, and guys who want to enhance their size. We talk about evidence-based approaches that are safe. So safety is my number one for everything that
Yeah.
I do. I offer safe approaches. And then I see guys who have low libido. We oftentimes think, oh, low libido is only a women's thing and men want to have sex all the time. That's not the truth. That couldn't be further from the truth. And I see
Right.
a lot of men that are bothered because they don't have the sex drive that they want.
That's fair. I love that. So I want to wrap this up because I don't want to keep you too long. What is something, I know I asked Dr. Michelle this earlier, what is something that you wish every client or person knew when it comes to sexual health, male pelvic health, women's sexual health, your your bread and butter?
Yeah. I would say it's a problem if it's a problem. And if it's not a problem, it's not a problem. So I have
I
people
like
that
that.
say, okay, I have a lot of things that fill my cup. And I just don't think that having sex is a part of my life anymore. And I would say, well, does it bother you? And they're like, no, I could not care less. And I would say, then I couldn't care less either, But when
Hmm.
I see people that say, look, it's not really a problem for me, but it's impacting my relationship. And I would like it to be easier, rather than it being such an obstacle every time that my partner wants to engage, I can help that person. And I would
Right.
say this as my final message. The question when it comes to all these things that I treat is really not whether or not I can help someone. It's how does someone want to be helped? As you can see in my office, I have a lot of tools in my toolbox. And there are some people that when I go through all the options, they're like, I'm not really feeling anything
Yeah.
that you're putting down. I say, I hear you. This is what I have to offer, but if none of this is going to work for where you are in your current life, then I totally get it. But it's not that I can't help them. It's just maybe they're not willing to try some of the therapies that we have. With
Sure.
that being said, I like to be on the cutting edge. because I know we still have a lot of gaps in terms of how we can help people. We
Hmm.
cannot solve everyone's sexual health problems to date, but I'm on a mission to find all these therapies. And fortunately, we get to work with a lot of people
I
that are
love
putting,
it.
yeah, the time, money, and resources into novel therapeutics. And my mission is to know more about it, and to know what's coming in the pipeline so that I
Yeah.
can be one of the first people to educate my patients on evidence-based and safe therapies.
Well, and I think that's what makes you so great at what you do is because I think all of us in the healthcare field can easily get swept up in just that tunnel vision of like, okay, I've got 8 erectile dysfunction cases today, and it's going to be the same tomorrow and the same the next day. And so you're kind of like, okay, these things work, these, not even like thinking about the other things out there. And so to constantly be educating yourself and like looking at the new evidence and looking at the new research and saying what else can help these people, because I agree. I think male pelvic health, for me at least, and personal opinion, but like it almost seems more underserved than female pelvic health. Just in the amount that I think women were more inclined to talk to our friends about it, tell our moms what's happening. We're going to Google and like going down the rabbit hole. We see it on social media. There's a bigger presence, especially with female pelvic health. And then men, it's like they're not talking to their buddies about this. They're definitely not calling up their dad to ask him about his testicular pain. And then they're not seeking help. And when they do, oftentimes it is that like, oh, well, I've just been on low dose antibiotics for 6 years because my doctor told me it was prostatitis. Right. And so there's like that medical gaslighting or like dismissal of just like, we've done what we can for you and there is no more. So I think as, pelvic floor PTs, as urologists, as other providers in the healthcare space, it is our duty to make sure that we are paying attention to what's happening around us and what new information is out there that can help us serve our people a little bit better and get better, results. We want people to be happy and healthy.
Yeah. And then I would say with this final message is I want people to build their team. It's like, and again, I love so many comments that Rachel Rubin makes. So I'm going to give another comment that she said. It's building your pit crew, right? It's like our
Yeah.
patient is like the race car driver. And so you like stop and they're changing the wheels and you have all these people that are on your team to like, keep everything in working order. And so if like, let's say I've exhausted the treatments that I have to offer and I want to send them to, let's say, someone like you or like a sex therapist, is I'm not telling my patient I can't help you anymore. I'm saying I want to add someone to our team, right? I'm still on
Yes.
your team, but we're going to load the
Hmm.
boat, you know?
Yeah,
And so, and
absolutely.
people, it's really hard to be advocates for our own healthcare, but I want people to build their team and I want them to build it before they actually need people, if they're able to
Hmm.
do that. Because when you're in an emergency, you need someone to call. You need like, the emergency, contact list. And so it's
Right.
nice to have, a couple key people on your team so you have someone to call when you're in an emergency. So you're not seeing a random person in urgent care who doesn't know anything about you. So
Hmm.
build the team and curate the team. Don't just have someone on your team that like someone says, oh, this person's going to be on your team. Like, fine, you got to like pick and choose and find them and doctor shop. It's okay to doctor
Right.
shop. No problem with that. I don't understand. Oftentimes we just uh, sort of are satisfied with the status quo and whoever assigns us our primary care provider is the one that we see. And I couldn't disagree, more about that. We have
Yeah.
to curate our own team and our own pit crew.
Yeah. No, I absolutely agree with that. And it's easy. I think we're, and again in the traditional healthcare system, you are just kind of like shuttled through the doors. You go with who your insurance covers, right? I have to find someone who takes this specific carrier and I can't see any we can, but that's kind not really how we've been indoctrinated, right? Like we're all kind of taught like, oh, you see who your specific insurance coverage covers and that's your doctor. And whoever else they might refer you to, that person also needs to be within this little spectrum, right? On this short list of who my insurance will accept. And I think that's why so many people don't like, they do just kind of accept like, oh, well, that's the doctor that I got stuck with, right? And we forget that we have the power to do our research and make those choices and decide whether it's I'm changing my insurance or I'm going to see this provider cash pay because I know I'm going to get a different quality of care here versus, being shuttled in and out of a room in 5 minutes and sent a script and not really being heard. Um, so I absolutely agree with that. And I think a lot of people who are coming to both of us for the, plethora of different issues that people are facing, they don't always have that pit crew in place. So yeah, I think that's fantastic advice for anyone out there, including myself. I'm like, who is on my pit crew? Um, okay, so how do people find you? Website, Instagram, email, TikTok? I don't know. Where are we?
So the easiest way to find us is our website, which is primeinstitute.us. If anyone is interested in learning more about our services, it has all of our services listed, including some of the therapies that we offer our patients. If anyone is interested in seeing us, it's easy. You can just submit an online consultation request, and Valentina will reach out to patients, the next business day to schedule an appointment or at least to tell them more about the services that we offer. My Instagram handle is Amy Pearlman, MD. I also have a couple of podcasts online. One is Fertility and Other F Words, which you can find us on YouTube at Doctors Amy and Larry. I do that podcast with a very famous urologist in Houston. And then I have another podcast with Urology Times called Pearls and Perspectives that you can find on YouTube as well.
Oh,
Just trying to get
clever.
out there and
I
educate
like that.
people, because the reality is most people are not going to see someone like you or me, right? But the
Right.
goal is to get under the community to at least give people the education where whatever healthcare provider they do see, they at least now have the foundational knowledge where they have questions that they can ask, and we
Yeah.
give them the power to advocate for themselves.
Yeah. Yeah. And I think that's the shift, right? Is that we're giving power back to the people to make informed decisions about their health. And before, I think the internet and ChatGPT and Google and all the things, it can be frustrating sometimes, to have someone walk in and be like, well, I Googled this and this is what's going on with me, right? But it in so many ways is so helpful because they are educating themselves and then they know these are the types of people that I need to actually see that can help me with what I'm facing. So yes, amazing. So Amy Pearlman, MD, Michelle is Michelle Pearlman, MD. Yes.
Michelle is, let me just verify. Give me 1 second here.
And
Yes,
primeinstitute.com.
Michelle Pearlman, MD on Instagram.
Okay,
And then
perfect.
primeinstitute.us.
Well, thank you so much. This has been fun. I could pick your brain for hours. There's so many questions I have, but I so appreciate you taking the time. Would love to do this again sometime. Thank
This is
you.
great. Thank you.
And please thank your sister for